which is also known as Cholodochal Cyst. Type 4 cysts are divided into 4A and 4B. 4A are multiple intrahepatic and extrahepatic cysts, and 4B are multiple extrahepatic cysts. Type 5 is also known as Caroli's disease, which consists of a single or multiple dilatations of the intrahepatic ductal system. And this is exactly what I said. This is 1A, 1B, 1C. This is segmental dilatation, diffuse dilatation, true diverticulum. This is the dilatation of the intraductal part, and this is Caroli's disease, intrahepatic dilatations. Etiology. The cause of cholodochal cyst has not been established. Many causes are there, like congenital weakness of the bile duct wall, then congenital obstruction of the bile ducts. Reovirus RNA has been detected. A high frequency of an anomalous junction of the pancreatic and common bile ducts. So there are increased chances of cancer in these cases because the collections the collections become stagnant in the dilated part of the CVD, the pancreatic collection. Clinical features. Disease often appears during the first months of life. Usually vomiting, irritability and failure to thrive may occur. Physical examinations. On physical examination, you may find a hepatomegaly and a palpable abdominal mass. In older patients, epigastric pain, which may result from pancreatitis, is the most common symptom. Intermittent jaundice and fever may result. The classic triad, consisting of abdominal pain, jaundice, and a palpable abdominal mass, is observed in less than 20% of the patients. The diagnosis is best established with ultrasonography. MRCP is being used nowadays to exactly know the anatomy of the thing and to evaluate the extent of the cyst and defects within the biliary tree and to detect an anomalous junction of the pancreatic biliary ducts. In practice, usually most pediatric surgeons rely on an operative cholangiogram to define the extent of intrahepatic and extrahepatic disease. The preferred treatment for cholodochal cyst is surgical excision of the cyst with reconstruction of the extrahepatic biliary tree. That was exactly done in our case. Simple decompression and internal drainage should be done only when the complicated anatomic characteristics do not allow complete excision. Long-term follow-up is necessary. Now, as in this patient, we had postoperative complication. That's why I will be describing something on postoperative complication. And that resulted in the patient staying with us for a long time. Now, postoperative complications can be subdivided into complications related to surgery and anesthesia. Anesthetic complications are those which are related to the anesthesia, including hypoventilation and changes in the level of consciousness. Well, postoperative complications related to surgery may either be general or specific to the type of surgery undertaken. Well, in this case, there was no specific complications related to surgery. The common general postoperative complications are hemorrhage, pneumonia, UTI, atelectasis, wound infection, DVT, and pulmonary embolism, fever, myocardial infarction, anaphylaxis. Now, postoperative fever, as it was present in our case. The causes are pneumonia, infections, UTI, DVT, abscess, medications. It can be of two types, non-infectious and infectious. If the fever occurs in first 48 to 72 hours, then usually it is due to non-infectious cause. If it is after that, then it is due to infection. Now, wound infections. Surgical site infections are classified into incisional, which can be superficial or deep, or organ space, which affect the rest of the body other than the body wall layers. Superficial incisional SSI is more common than deep incisional SSI. Now, definitions. Superficial SSIs. Infection involves only skin and subcutaneous tissues of incision. Deep incisional SSI. Infection involves deep tissues such as fascial and muscle layers. This also includes infection involving both superficial and deep incision sites. Organ space SSI. Infection involves any part of the anatomy in organs and spaces other than the incision. Now, this figure actually explains what I said. Skin and superficial SSI. Then subcutaneous tissues is infected. Here deep tissues, fascia and muscle, deep, and organ space in organ space SSA. Now, what are the different severity of infection? Now, contamination is only presence of a non-replicating microorganism. Colonization is presence of microorganism, replicating microorganisms to the wound without causing any cellular damage to the host. Then there comes the critical colonization. Here there are no local signs of infection, but only the wound healing is delayed. Then there is local infection, where there is local damage, local signs of inflammation like redness, heat. And finally there is systemic inflammation. The bacterial load is so much that it results in systemic manifestations of the infection. Now some important definitions in infection. First, systemic inflammatory response syndrome. Or criteria for SIRS are considered to be met if at least two of the following four are present. Hyperthermia or hypothermia of more than 38 degrees Celsius or less than 36 degrees Celsius. A heart rate higher than 90 beats per minute. A respiratory rate higher than 20 breaths per minute, or arterial carbon dioxide tension lower than 32 mm of mercury. White blood cell count higher than 12,000 per microliter or lower than 4,000 per microliter with 10% immature forms. Now sepsis. Sepsis is defined as the presence of infection in association with SIRS. Severe sepsis. Severe sepsis is defined as sepsis that is complicated by end organ dysfunction, as signaled by altered mental status, an episode of hypotension, elevated creatinine concentration, or evidence of DIC. Septic shock is defined as a state of acute circulatory failure characterized by persistent arterial hypotension despite adequate fluid resuscitation or by tissue hypoperfusion that is unexplained by other causes. Bacteremia. Bacteremia is defined as the presence of viable bacteria within the liquid component of blood. And multiple organ dysfunction syndrome. It is defined as the presence of altered organ function in a patient who is acutely ill and in whom homeostasis cannot be maintained without intervention. Now, our patient, the postoperative complication that she had, we had three things in our diagnosis. First, abdominal wall cellulitis. So the term cellulitis, so I will be just describing those things. Abdominal wall cellulitis. The term cellulitis is commonly used to indicate a non-necrotizing inflammation of the skin and subcutaneous tissues, usually from acute infection, and usually follows a breach in the skin. The necrotizing infections of abdominal wall are usually secondary either to perineal or to intra-abdominal infections. But in our case, there was no intra-abdominal infection or perineal infection. Skin infection without usually the cause of cellulitis are streptococcus, staphylococcus. Malaise, chills, fever and toxicity, circumferential cellulitis suggest severe infection. For indications for emergent surgical evaluation are violaceous bullying, cutaneous hemorrhage, skin sloughing, skin anesthesia, rapid progression or gas in the tissue. The next thing we should know is necrotizing fasciitis. Now this is common in traumatic or surgical wounds. Infection most commonly develops in episiotomy sites or abdominal incision sites. Subcutaneous gas production occurs, so-called gas gangrene. This is also known as gas gangrene when basically there is more Clostridial organisms are present. But usually it is found that the mixed organisms are involved in this. Tissue breakdown and muscle necrosis may occur rapidly, particularly if Clostridial organisms are present. Surgical removal of the devitalized tissue is required, as is high-dose parenteral antibiotic therapy. Melanese gangrene. It is a form of gangrene of the skin and subcutaneous tissues, usually following an operation, caused by a synergistic interaction between microaerophilic non-hemolytic streptococci and aerobic hemolytic staphylococci. It produces extensive tissue necrosis with ulceration. Now, it enlarges in a period of days and may not respond to antibiotics if central necrosis is not excised. The muscle fascia is usually preserved.